So I will focus on giving you cases, and I will go over the basics throughout the presentation as well, but I will focus on cases and calculations. Okay. Let me see here. So, okay, good. Do you see the slides?
Yes, we can see it.
Okay, good. So I will skip those since we talked about them. I'll just remind you 8% between SVC and PA is considered the significant cutoff for shunting, for what we consider shunting, okay? I will give you, this is a quick example here. This is SVC 68, IVC 71, RA high 69, RA low 53, RV 70, PA 70. Anything wrong? And I'll just say it quickly here. Basically, there is no step up, no significant step up anywhere. 68, 71, 70. There is only one low number, RA. And be careful when you see this. This is not really a shunt. This is no step up between RA and PA. This is actually the caveat of using the RA. The fact that the RA receives 3 streams, and here you're probably capturing the coronary sinus or a large amount of coronary sinus in this sample. And that's why it is low. So it's not really a shunt or a step up. So be careful when you analyze those. And when you sample the RA, try to aim for the lateral RA wall, away from the coronary sinus, mid-lateral RA wall. That's what we shoot for. Like on this cardiac silhouette, yes, try to touch the cardiac silhouette at the mid-level for the RA. We mentioned also last week right to left. We know left to right manifests as a step up in oxygen saturation between the SVC and PA. How about right to left shunt? It will manifest as a step down in oxygen saturation between the pulmonary veins and the aortic O2 sat. Okay. Practically, though, we don't do pulmonary vein sampling. We only get aortic sat. So practically, we consider that there is a right to left shunt when the aortic O2 sat or the arterial O2 sat is less than 95%, which without resolving with oxygen and deep breath. Basically, if you have somebody with a left to right shunt or with a shunt suspicion who is also hypoxic, the first thing you should consider is that he's having a right to left shunt. Frequently, that's not the case. It could be just COPD, pulmonary edema, or sedation, the most common cause of hypoxia in the cath lab. So you make sure you give him oxygen, 2 liters, although you don't want to keep him on oxygen for your calculations, but at least initially to make a diagnosis, you give him oxygen, you ask him to take deep breath. If that oxygen sat goes up quickly, then you know that this oxygenation is low for other reasons. And in this case, you don't consider there is a shunt, and you consider that the pulmonary venous O2 is equal to that low O2 sat. Like we consider both of them 92%, for example, which is the same as his arterial sat. On the other hand, if O2 sat does not improve and you highly suspect right to left shunt, then you consider that arterial O2 sat, which is, for example, 92%, this is the step down. And we consider the pulmonary venous sat as 98%. So when the arterial sat is due to right to left shunt, we consider the pulmonary venous O2 as 98%, and the arterial sat as a step down, 92%, 88, whatever it is. Okay. And you can directly sample the left upper pulmonary vein in patients with ASD or PFO relatively easily. That's always an option as well. Definitely an important option in complex cases. All right, I will go over some cases and go over some calculations, okay? So this is a, so I want you to look at those numbers, okay? This is high SVC, low SVC, IVC here, 74%, RA, RV, and PA sat, and SA. So look at the numbers. There is a step up in oxygen saturation. This is an easy case. I'll go over it quickly. I'll ask you, or I will try to test you in the next cases. So here what you can see, so there is a step up in oxygen saturation, at least if you take the two number, SVC or IVC to PaO2, there is a significant step up. Then you look, the step up is at the level of the SVC, between high and low SVC. Most likely this is sinus venosus ASD, okay? Now I'm going to ask here how to, or I'm going to show you how to calculate the QP to QS, okay? And by the way, maybe one note before that, how to calculate the mixed venous O2 saturation. If you want to, you can just use the SVC before the step up. You can use this as the mixed venous O2 saturation, 70%. If you want to use the IVC in the equation, it's fine, but be careful, use 3 of this plus 1 of the IVC. Know which SVC you pick. You always pick, when you have a shunt at the level of the SVC and IVC, and you want to use that calculation, always take the SVC or IVC before the step up in your calculation. So here I would use 3 times 70 plus 74 divided by 3 for mixed venous O2. Just, of course, don't take the 83. That's already past the step up. So anyway, the QP to QS, the QP, which is the pulmonary circulation flow, uses those two arterial sat, the pulmonary arterial and the pulmonary venous, the pulmonary saturations. Whereas the QS, the systemic circulation, uses the arterial O2 and the mixed venous O2 before the shunt, okay? So those are the systemic circulation, SA and V. Those are the pulmonic circulation, in between. Okay, those are the two more extreme chambers. Those are the two in-between chambers. You have to remember that kind of square very well, because this is how you make your calculation. And those are the numbers you should seek as you're trying to make the calculation. So the systemic flow, QS, this is the Fick equation, which you should, again, know very, very well. You should always be able to memorize it and cite it. So it is O2 consumption divided by the arterial O2 content minus the venous O2 content. For the systemic circulation, this is the arterial O2 content, SaO2, and this is the venous O2 content, MvO2 before the shunt, mixed venous O2 before the shunt, okay? Which was 71% if we take the IVC into account. And then we have the 1.36 by hemoglobin. So this is the systemic flow. On the other hand, the pulmonic flow is O2 supply by the lungs. Again, it's the same Fick equation, divided by venous O2, pulmonary venous O2 saturation minus pulmonary arterial O2 saturation. Keep in mind, of course, that the O2 supply by the lung is equal to the O2 consumption by the tissues. What goes out comes in, or what comes in goes out. So that's why those two numbers, O2 supply, O2 consumption, are equal. So when you do QP/QS, it eventually turns out to be systemic sats divided by pulmonic venous sats, by the pulmonic sats. So QP/QS, systemic divided by pulmonary when it comes to sats, okay? Keep that idea in mind, it's very important. So eventually it comes out to 96 minus 70 or 71 divided by 96 minus 84, okay, which is the PA sat. That comes up as 2.1. I want you to be able to make that quick math as I alluded last time. So in somebody who has purely a left to right shunt, whose arterial O2 sat is over 95 or less than 95, but we assumed it's not right to left shunt, The calculation is simple. You always take that number, the arterial sat, minus the lower number before the shunt. So 96 minus 70 divided by 96 minus 84. So you can do the math as you're doing the case. Or in other terms, if somebody has 100%, it's 100 minus 70 divided by 100 minus 84. Very quick calculation, okay? I want to point out here, if you look at that calculation, realize how important any error in those numbers is. Imagine that you have only 2% error in measurement in those sats. And I show here the math, 2% up in one, 2% down in the other, you end up with a QPQS that goes from 2.1 to 1.6. So that shows you that it's important to have no errors and try to sample all samples as quickly as possible or as simultaneously as possible. That's why I sample them on the way back. So I do it quickly, PA, RV, usually at least 2 samples in the RA, 2 SVC, and eventually IVC. So I try to do it quickly when I'm sampling those. Or when I'm doing just the screening PA and SVC, I do those simultaneously from the side arm of the sheath and from the tip of the PA catheter, okay? Because if the patient is asleep and wakes up, his O2 consumption will go up and those numbers will change normally. Your mixed venous O2 will change normally. It will, it will go, O2 consumption actually will go up, which means the mixed venous O2 will go down. So that number will go down regardless of the shunt. So be careful with that when you're sampling. Another thing I wanted to highlight quickly is oxygen therapy. We don't like to make those calculations while the patient is on oxygen, okay? Oxygen, if I ask you, what will happen if I give this patient oxygen? Here, imagine I give this patient oxygen. What will happen to the step up? Will it exaggerate or will it stay or will it get less? Anybody knows?
Get less?
No, it will exaggerate, and I will explain why. So if we give high flow oxygen, okay, especially over 2 liters of oxygen, what happened, it's the simple explanation, it could be complicated, but the simple explanation is that the shunted blood will have a lot more oxygen now, okay? It may not show up under the arterial or the pulmonary venous sat because it's already 100%. Yet the oxygen content through soluble oxygen, dissolved oxygen, will go up dramatically. And all that oxygen will be dumped into the shunt. So now we have a lot more oxygen being supplied through the shunt. And keep in mind that the mixed venous O2, it's being damped here at over that 70%. And whenever the mixed venous O2 is on a steep hemoglobin oxygen dissociation curve, so all that oxygen will make it rise dramatically more, okay? So giving somebody high flow oxygen will increase the step up, and subsequently or consequently, it will also increase the QPQS, so it will exaggerate it. If you plug that equation, it will exaggerate the QPQS and will exaggerate the step up. If you use oxygen, it's not contraindicated to use oxygen and calculate shunt, except you have to use the true Fick equation, which actually account not just for the O2 sat and the hemoglobin bound oxygen, but also it adds here, there is another plus for the dissolved oxygen, which goes up in case of high flow of oxygen. So you can do Fick. I'm not telling you to do that, but just know it's feasible. You just have to plug the true Fick equation, which accounts for the soluble or dissolved oxygen, okay? How to calculate PVR in case of shunt? The thing here I want to highlight, interestingly, PVR is like the QP and QS in terms of chamber. PVR is you use the difference in pressure between those the pulmonic chamber. So PVR is you use the PA pressure, mean PA pressure minus LA pressure. SVR, you use the systemic pressure, systemic blood pressure minus the RA pressure in your calculation, okay? So that helps. But this is the idea I want you to know here. You're used to plugging in the thermodilution cardiac output. So you put LA, mean PA minus LA divided by thermodilution cardiac output. But I don't want you to do that. That's wrong. And this is the idea I want to get to. PVR is mean PA minus LA, those two pulmonic chambers, inflow, outflow of the pulmonic circulation, kind of like the O2 sat in QP, but divided by QP, not by thermodilution cardiac output and not by QS. Remember here, we have two cardiac outputs in shunts. Know which cardiac output to use. For the systemic vascular resistance, we use a QS. For PVR, we use QP. So you should calculate the absolute QP here. It's not enough to do QP, QS. You should calculate the absolute thing. You can use the assumption here, the equation that assumes what's the O2 supply or O2 consumption. But you have to calculate that to calculate PVR. Don't use in shunts, thermodilution cardiac output is inaccurate. It correlates with QP because you're measuring the output on the right, but it's very much diluted by that flow from left to right. And eventually your curve is much prolonged with it. So it's not a good estimate of QP. It will very much underestimate the true QP. So I prefer not to use thermodilution cardiac output. The worse the shunt, the worse thermodilution becomes. This is another case here. So this is an oximetry run, okay? This is an IVC, so IVC 77%, high SVC 84%, low SVC 90%. Then you have those RA 88 and so on, and PA eventually. To make it simple, I think eventually look at the first ones and the last ones. Then eventually you sort out the small things in the middle. But the most important thing is the beginning and the end. The things in the middle help you sort out where the actual step up is. They don't often help you in the math. They help you sort out what's the level of the shunt. So, okay, this is IVC, SVC, and those rest. Then the left upper pulmonary vein, 99%. They crossed an ASD here and measured it. And aorta is 96%. So is there a shunt and where is it? Can anybody tell? Where is this?
There is a step up from high to low SVC, so it could be sinus venosus. I think the low RA can be from the coronary sinus, so that's not a shunt.
All right, that's a very good thought. So it could be sinus venosus. Now the problem, compare the high SVC to the PA. There isn't much of a step up there. What does this tell you? And by the way, those are real numbers from real patients. So that shows you in real life they are harder than in a book. So what does this tell you? That tells you that, well, if I use those numbers, high SVC to PA, there is no shunt. Okay, there is no significant shunt. Yet you know there is a big step up here. That's one hint. There is a second big hint. Your IVC is a lot lower than SVC. So whenever you have major, and that's one thing that's harder to sort out, whenever you have a major discrepancy between IVC and SVC, it could be vice versa. Always think maybe there is a shunt at the level of the higher O2 sat chamber. So normally we say IVC sat in a resting patient, not in shock. It should be higher than SVC. Here you have an IVC that is a lot lower than the SVC. That by itself tells you, well, there is a shunt at the SVC level. Actually, even the 84% is a step up. Okay, you're just not capturing the full spectrum of the step. But the problem, if you have a shunt at the level of the SVC, that shunt will stream downward to the low SVC, but it will stream upward to somewhat to the high SVC. So you're not going to get a pure SVC, unshunted SVC. frequently and practically. So for that reason, I think the true mixed venous O2 is IVC sat. Okay, and the true step up for you, that's important to realize, because you need to know what am I using to calculate my step up. The true step up is between IVC and PA. When you're plugging the numbers, that's what you use, IVC and PA. You got me? What you mentioned is great, because it is a hint that the shunt is at the level of somewhere in the SVC, a high to low, and it's probably sinus venosus. But this is the bigger hint between IVC and SVC. And you will get a fluctuation. For example, the low SVC is very high because it's getting directly the stream of the left-sided shunt, the left-sided circulation. So it will be higher than the rest because it's relatively much more of that shunt flow. Eventually here that shunt mixes and you get a better representation of the eventual shunt flow, especially at the PA level, okay? Here, this is wrong because maybe it's capturing a little bit of the coronary sinus, that RA. All right, so that's the point I want to make. It's the IVC to PA. So this is a step up. If I want to use a number, it's 9%. Yes, 9%. So calculate now the QP over QS. Can anybody make quick math?
1.9.
Good. What numbers did you use, if you can tell us?
So the aorta 96 minus IVC 77 divided by 96 minus 86.
Okay, excellent. It's 1.9. You are correct. Good answer. So it is significant, over 1.5 sinus venosus ASD. Now, here I want to do a hint. I want to, make a comment. How about using, for the pulmonary venous sat, why not use 99? Meaning your equation becomes 96 minus 77 divided by 99 minus 86. Since we have the pulmonary venous sat, can we do this? It can. I mean, somebody can think so. And I've seen actually experts doing that in medical journals. I don't agree with it, because here's the thing. You're only sampling one vein. If you had the ideal pulmonary venous O2 sat is to average 4 veins, okay? If you are having step down, if you are having suspicion of right to left shunt in a hypoxic patient, then I would do that. I would use the pulmonary vein as my the sample pulmonary vein as my PVO2. However, in a case where I don't suspect right to left shunt and I'm only sampling one vein, my concern is the oxygen saturation of different quadrants of the lungs may not be the same. And I think in this case, the aortic sat is a better representation of the average of the 4 pulmonary venous sat. I think if you sample another pulmonary vein, it may be 95%. And this is kind of the average of them. So in that case, just because I know there is no right to left shunt, I would rather, because the O2 sat is high, the systemic sat, I would rather use 96 rather than 99 for the pulmonary venous sat. Okay, you kind of get the idea, because this is only one, not the 4. I think if you average the 4, it will come up 96%. And so this is how you plug your numbers, as I think Rakesh said, or 96 minus 77, 96 minus 88. Again, there is a question mark if you use 99 here, but I wouldn't. All right, here I have an explanation. You can read it when you review those. This is another case, a little more difficult. So I plugged in the numbers for you here. So these are the O2 saturation, SVC 58, 66 IVC, PA sat is 73%, pulmonary venous sat, here it was sampled, and here it's okay. It was the left upper pulmonary vein, but it's okay. Even though it's only one vein, it's relevant in this case. I would use it. So it is 93%. And the aortic systemic sat is 85%, okay? So look at those numbers and think of the shunt. Beside the shunt, we obtained, of course, pressure, and he has a very high PA pressure, 75/21, with a relatively upper limit wedge pressure, not significantly elevated. And this is his aortic pressure. And here we're giving you hemoglobin and body surface area. So if you need to calculate the actual QP, you can calculate it, not just the relative ratio. So what do you think here? Look at that. What kind of shunts do you have here? Is there a left to right shunt and is there a right to left shunt?
It's
So-
a bidirectional shunt.
Yes, good. So there are both. By the way, I consider there is significant step down. Well, when the O2 sat is, like I mentioned, less than 95% and not easily correctable, or in other terms, also when you have a step down of over 5%. Okay, so it's bidirectional shunt. Now, what is the QP to QS in this case? You don't calculate it in your mind, but maybe tell me what numbers you would use.
I think we should get first the Q effective and then calculate QBQS, because we need to subtract to get the accurate QB and QS, we need to get the net shunt flow first, right?
It's a good thought to get the Q effective, and I was to bring it up actually. But to calculate the QPQS, you don't need the Q effective.
Yeah, it's not going to be like accurate because
Exactly. It's not going to give you a good representation of the full picture. Yes, you are correct. But you can still calculate it. I mean, it gives you what QPQS will give you here. It will give you an idea about a net shunt. So this is a patient with clearly left to right shunt. You have a significant step up, and clearly right to left shunt. You have significant step down. QPQS will give you an idea of what is the size of the net shunt. Okay, what's the bigger shunt of the two and what's the net shunt? You know, it doesn't size any of those shunt. It only sizes the net shunt. You can still calculate it. I mean, I agree it's limited, but we still calculate it. And in this case, I would use 85 minus about 60% here, and I will use 93 minus 73%. Okay, so it will be 85 minus 60% divided by 93 minus 73%. And it will come up at 1.25. Okay, so the QPQS, that suggests that you still have the left to right shunt is bigger than the right to left. Not a whole lot bigger because the QPQS is 1.25. But as Ahmed said, don't be fooled. If you have bidirectional shunt, you could have a huge left to right shunt and a huge right to left shunt with a QPQS that is balanced and equal to 1. It doesn't mean you're in good shape here. Okay, so you have to calculate the absolute QP and the absolute QS and the absolute shunt in those cases. And here is the Derek last week commented on that. So I will allude to it. I will explain it a little bit. So in those cases, you have to calculate the absolute shunt. The absolute QP and QS. The other reason why this is important, I will mention, is that you need to calculate your PVR and SVR. So you need the absolute QP here to proceed forward. Because what's the important question here? The important question you're addressing here, can I close that shunt? And whenever you see, usually when we ask ourselves, can I close that shunt? You have to answer two questions. One, is the shunt hemodynamically significant? And this is kind of already answered by the step up. Frequently, it's answered by QPQS, but not in this case. Number two is, even if it is hemodynamically significant, is it already too advanced at the stage of advanced pulmonary hypertension and right to left shunt that I cannot close it anymore? I will hurt him by closing it. So those are the two questions to address. So we know it's hemodynamically significant here, but we will, one, prove it, and two, we will see whether he has irreversible pulmonary hypertension with an irreversible right to left shunt that will preclude closure. So in order to do that, we calculate the absolute QP and absolute QS. It's the same number we plug for QP, the pulmonary venous and the pulmonary arterial O2. We just add the hemoglobin numbers. And for the O2 consumption, there are a lot of equations. You can use any for that purpose. Here I use the standard one, 125 milliliter per minute per meter square by body surface area. That's why here I gave the body surface area. So you calculate the QP, then you calculate the QS, not, that's the QP-QS ratio in absolute. It will come up 1.25. Then to quantify the shunt, you use what you call Q effective. Q effective means what is the theoretical QP and QS had they been equal with no shunt. So in this case, the Q effective means there is no shunt. So in this case, there is no step down. So the aortic sat is equal to 93%. There is no step up. So the PA sat is considered, or the mixed venous sat that you use in this case is equal to 60%. That is the Q effective. It's a theoretical, not a real flow. Okay. So in that case, basically use that zigzag. You use 93% minus 60% for the calculation. So there is no step down, no step up. So 93 minus 60%. Those are your two values used in Q effective flow. No right to left, no left to right shunt. And that comes up to 4.2. So I use 93 minus 60. Keep in mind that Q effective, if you don't have right to left shunt, Q effective is equal to QS because PVO2 is equal to SaO2. Okay. But anyway, we have a right to left shunt here. So this is 4.2. And now you can do QP divided by Q effective. So if you want to measure QP-QS, the better than QP-QS to quantify shunt in every direction is to measure either the difference QP minus Q effective, or easier for you to conceive QP divided by Q effective. That will be similar in numbers to what you're used to as QP to QS. So here 6.9 divided by 4.2, that comes up as, I think, 1.7 or so. So that is significant. So we have a significant QP to Q effective, significant left to right shunt. That's a QP to Q effective. Then you calculate QS to Q effective. That's a significant, that's a significant right to left shunt. Not so much, it's about 1.3, not as significant, but the other one is definitely significant, the left to right shunt. You kind of got that equation. Another thing you calculate here, very importantly, is the PVR. Okay, and the PVR will be the mean PA pressure minus the wedge pressure, PA minus LA, basically. Okay, 43 minus 16, 27, divided by that QP. And that comes out to 4 Ud units. So that's very helpful. Can you close this shunt? So I have proven to you that the QP-QS or the QP to Q effective is significant in this patient. He has bidirectional shunt, but the left to right shunt is still large, and PVR is 4 Ud unit, SVR is 15 Ud unit, mean aortic minus RA pressure. Can I close the shunt? Or is there some other tests you need to do?
I think we need to do like vasoreactivity. So it's more than 3 Wods unit, but it's not very high. So it can be reversible. So we need to make sure that the patient doesn't have irreversible pulmonary hypertension. So maybe you can do vasoreactivity. Yes.
I think your answer is correct. I don't think it's absolutely necessary in this case. I'll show you some other cases. But I think in this case, I think you're definitely correct. In this particular case, it's okay not to do it. And I'll explain to you why. There are specific recommendations. And here is the thing. To explain that, I think basically my answer to this case is that, yes, you have bidirectional shunt, but the left to right shunt is still significantly large. And your PVR is not too high. Therefore, you can go ahead and close that shunt safely. But I will explain it a little more. I will define what is Eisenmenger. Eisenmenger, the way I define it, it's not from books. This is the way I always understood it. You need those three to call it a true Eisenmenger. Irreversible PAH that resulted from a left to right shunt. Okay. It has to be irreversible. Now, not all irreversible PAH are Eisenmenger. Eisenmenger needs more. It's the ultimate irreversible PAH that results from a shunt. So it's irreversible PAH plus reversal of the shunt, which becomes fully right to left or at least bidirectional. And the third condition, that's important one people don't realize, PVR should become at least equal or larger than SVR. Okay. Along those lines, PA pressure is equal or larger than systemic pressure. But this is the more important one. PVR equal or larger than SVR. Yet, in order to contraindicate a shunt closure, you don't need to have the full three. Okay? Eisenmenger is horrible, but even having those, and those are the guidelines, those things will contraindicate shunt closure. So based on the congenital guidelines, if you have pulmonary hypertension, ASD closure is indicated if there is a still net left to right shunt, as in this case, and PVR less than 1/3 of SVR and less than 5 Ud units. This is what they use. Those are the numbers they use. And in this particular case, we were 4 Ud units. We were way less than 1/3 of SVR. So I think we were fine to close it without further studies, although it's okay to do further studies, prove that 4 Ud units goes down to significantly less than the normal, which is a 3. Now, if your PVR is higher than those numbers, but you still have a net left to right shunt, I think those are the cases where you absolutely need to do vasodilator challenge if your PVR is higher than those numbers. The ACC guidelines don't want you to close the shunt if those numbers are over 2/3 SVR. But in my opinion, and according to the ESC, even when it's higher than 2/3, you can still do vasoreactivity challenge. So in my opinion, whenever you still have net left to right shunt and PVR is over 1/3 of SVR or over 5 Wood units, even if it is over 2/3, I would still do vasoreactivity challenge. Okay. So that's what it is here. PVR is okay. He has significant left to right shunt with a QP to Q effective over 1.5. So he has an indication for closure. All right. Any questions? And this explains kind of the idea here of limitation of QP/QS. And again, use here QP to Q effective. Okay. Any questions regarding this? I will keep going then. This is another, I think it's even harder, but more interesting case. I hope I'll get through it. So
I have one question, Dr. Hanna.
go ahead.
In this case, what level was the shunt at?
Well, here it's just an illustrative case. I didn't do a full oximetry run, so you cannot tell where the shunt is. I just gave you here SVC and PA sat, so I didn't give you. The assumption most likely ASD in an adult patient, okay? But yes, you need a full oximetry run to tell that. But except that your calculation, but that shows you that your calculation of QP, QS, Q effective, the size of the shunt and the reversibility are not related to where the shunt is. They are related to your initial numbers, initial and end numbers. Okay. You don't need the intermediate numbers to calculate QPQS. The intermediate numbers only help you tell where my shunt is. All right. So this is another interesting case that I had in a couple of years ago. I did not do the hemodynamic study. It was done at another institution, but I took their numbers and recalculated. They got good numbers, but they didn't calculate them correctly, in my opinion. So I got them and recalculated them. It was a great case. So this is a 66-year-old man with a biventricular failure and hypoxemia, elevated JVP, peripheral edema, pulmonary edema. So he has biventricular failure clinically. He has a holosystolic murmur with a palpable thrill, very loud murmur on the left lower sternal border. The echo shows the following: dilated LV and dilated LA, normal EF, severe pulmonary hypertension, yet normal right atrial pressure. Right heart has not failed yet by echo, although clinically he seems to be in failure. His RV is normal in size and function, and he had a VSD. Didn't seem too large. It's 1 centimeter, and it was read by the echocardiographer as a restrictive VSD, meaning not very large, with a relatively high velocity. So here the question, is this pulmonary hypertension related to that VSD, or is it more an incidental VSD in somebody with pulmonary hypertension from another reason? Is it an incidental innocent VSD? So this is the right heart catheterization and the numbers, okay? So this is the SVC on him, 39, RA 40, 49. You can see step up at the RV, and 54% at the PA. His arterial sat without oxygen is 92%. It doesn't get better with breathing or with 2 liters of oxygen, okay? Not significantly better. So looking at that, is there a significant O2 step up on the left? On the right? So I will answer it to you. Yes, there is significant step up, 39% to 54%. It's way over 8%. And to answer your question, Aruj, the step up here is at the level of the RV. But don't use the RV number. Always use the beginning and the end, which is where the flow is best mixed. Okay? So I'll use this. This is a step up. Now you do have a step down on the left between, I would call it 98% to 92%. Okay? Again, whenever you have less than 95%, that is due to a shunt, I consider the PvO2 98%. Not very accurate, but it gives you an idea. All right, so he has, again, bidirectional shunt. So here we will do, again, the measurement of QP, the absolute value. Always, whenever you have bidirectional shunt, it's important to calculate absolute QP and QS and the PVR and SVR from those absolute values. So anyway, so here are the calculation. I'll run them. Anyway, QP is equal to 3.8. QS is equal to 3.15. QP/QS is again mild, 1.2, but that's not the way to estimate the shunt. Like we said previously, we need to do Q effective, okay? This case, I didn't even do Q effective. We could, and we probably should, but the numbers here are massive, 39 to 54. That shunt is definitely large. The left to right shunt is definitely large. I didn't need to do Q effective to prove it, okay? The more important thing for me at this stage with this pulmonary hypertension, 106/30, is to determine. So he has PA 106/30, and he has right to left shunt. So I want to determine, is the shunt already at an irreversible stage, irreversible PA pressure? At a stage where I cannot close that VSD. So this is why PVR is important. So I used PVR calculation. Anybody can tell me what's the PVR here? Calculate the PVR for me. At least give me the numerator of the PVR. Anybody? Not Ahmad, somebody else. Can you give me the numerator of the PVR?
55 minus 18.
Huh? Sorry? 50, what did you say?
37.
Yeah, okay, 50. And you divided by what?
The 3.8, I think it was.
QP, correctly. Yes, you divided by the QP. Excellent. You can make a quick math. Okay, so it is basically, it's like you said, 37 divided by 3.8. It is 10 almost, right? So he has PVR of 10 Wood units. I didn't measure the I didn't provide the calculation for the SVR here, but his SVR was, it was only a little bit higher. It was 13 or so. So his PVR to SVR ratio was really high, and his PVR in absolute value was really high. For a shunt, over 5 is very high. So that was worrisome. So what's the next step in this case? Here, I think something Ahmed mentioned earlier. Here, it is very important to do vasoreactivity study. So it is pulmonary hypertension is severe with severe PVR. I'm worried whether we can close it. And if you go by the American guidelines, we probably shouldn't close it because PVR is way higher than 2/3 systemic value. So we probably shouldn't close it, but I think based on ESC and some other experts, I think it is useful to do what Ahmed said, which is vasoreactivity testing, okay? Especially that I think he still has a good left to right shunt. It's still predominantly a net left to right shunt, okay? And the QP to Q effective is very high here. So here's what was done. A vasoreactivity challenge was done using nitric oxide. And I want you to look at those numbers. It's a very informative case. So with nitric oxide, look at what happened. The PA sat, so nitric oxide is a pulmonary vasodilator. The PA sat went up to 83%, okay? The arterial sat went up as well. We didn't give him more oxygen. The arterial sat went up from 92 to 100%. So look at those numbers. The PA pressure did not change much. It remained the same. Wedge didn't change much either. Okay. So what does this signify? So two major findings to summarize it. If you look, I know if you look at that, it's overwhelming, but two major findings: more O2 step up and less O2 step down. That's how I translate it. So what happened with nitric oxide?
I think the right to left shunt was stopped, so there's only left to right.
Yes, the right to left shunt was stopped while the left to right shunt went up. Why is it? Why did this happen? Anybody knows why did this happen?
Like relief of the pulmonary hypertension from increased resistance.
Yes, you totally relieve the pulmonary vascular resistance. Okay, you relieve the outflow into the outflow of the right heart into the PA. Okay, now in this case, the left to right shunt will dramatically rise and you will have no right to left shunt. Okay, all the flow will become going left to right because you suddenly collapse the resistance on the right. Okay, so what does this tell you? Even without making any math, your PVR, what happened to your PVR here? Your pulmonary vascular, yeah, it collapsed. That's why you were able to reverse the shunt so dramatically and increase the left to right shunt. And you can make the math here. Of course, we did the math. What happened, the QP to QS became 3, which is good. Even in bidirectional shunt, that value is still relevant as of how much you're having of a net shunt. So your net shunt went up dramatically from 1.2 to 3. And actually, we don't have any right to left shunt in this case anymore. QP became 10 liters per minute and PVR becomes 3.4. So we went down from 10 to 3.4, close to normal. Okay, so QP went up. This QP here went up. And PVR dramatically dropped. QS did not change much because even though the right to left shunt dropped, the QS is increasing to pump more blood onto the right side. So QS did not change much. All right, so now we can tell that we had full reversal of shunt and annihilation of hypoxemia with pulmonary vasodilator and PVR collapse. So this is a shunt that we can close probably with vasodilator therapy in a specialized center. But this is a shunt that can be closed with pulmonary vasodilator therapy perioperatively. Now I think to keep in mind, the PA pressure has not changed. How come? We collapsed the PVR. How come the PA pressure did not change?
Because of increased flow, because the PA pressure is like determined by the PVR and the flow. So flow increase and PVR decrease, the net flow is okay.
Exactly. You are correct. So PA pressure, as by the equation, it is almost equal to QP times PVR. That's how we calculate the Ohm law. So it remains unchanged, but it's a different flare of PA pressure. The prior PA pressure was low QP, high PVR. Now it's high QP, low PVR. It's a much more benign PA pressure for the same number. Its components are different. It's much more benign, much less worrisome. Okay. All right. It's an unusual case. This is rare. Most VSD you see in adults are typically small, insignificant VSD with no hemodynamic compromise. Unless they have caused a problem in childhood, they don't cause problem in adulthood. This is an unusual case where you had a moderate VSD that was probably not significant in this patient for most of his life. He's 66 years old. It's very rare for VSD to manifest as significant at this age. But probably because it's one of those rare cases where that VSD was probably all his life 1.3, 1.6, in the moderate range. Then as he ages and develops diastolic dysfunction, he starts shunting more across the VSD as the LV pressure rises or as he develops hypertension. So you start having more shunt from the left to the right, and that VSD becomes more significant with age. So it's an unusual case, but I do think it's the VSD that's a major culprit in this patient's case, and it should be closed again with careful perioperative management. Again, despite the age of 66, he has a nice congenital EKG, and I want to show you that. What does he have on that EKG? Any interesting finding? He has a lot of things, but there is one interesting finding. What kind of ventricular hypertrophy he has on this EKG?
I think both are hypertrophied, right? And
Yes.
Sorry.
Yes, both have hypertrophy. There is one sign I want to point to. I don't know if you know it. It's called the Katz-Wachtel. Have you heard of it? Katz-Wachtel sign.
Yeah, when we have like long R and long S and V3 and V4.
Good. Or any of the mid-precordial lead. Yes, here we see it more in V4 and V5 and V6 actually. Yes. So it's a huge R and a huge S in V4, V5, V6. Normally, when you have hypertrophy of one ventricle, it's one of them that is high, not both. Here you have hypertrophy of both ventricles. So you have a huge R and a huge S. You have other criteria for biventricular hypertrophy. He fulfills the voltage criteria for LVH in many ways. He also fulfills voltage criteria for RVH by the S being smaller than R in the V1. But the Katz-Wachtel, big R and big S, very big R and big S, more than 4 or 5 squares in V4, V5. Sign of biventricular hypertrophy, especially Eisenmenger, well described with VSD with Eisenmenger. I'm almost done. If I know some of you have to leave, I want to show quickly a simple case for those of you who can stay. It's an interesting case. I want to make some just discussion of few things. You will see that commonly. It's an adult type of case. So this is a 57-year-old female, morbidly obese. She has severe RV failure, unclear PA pressure by echo. So we did the right heart cath, and those are her numbers. RA, RV, PA is 120/30 with a mean 63. So very high PA pressure. Wedge pressure is normal. So it's already pre-capillary pulmonary hypertension. This is aortic pressure. This is her cardiac output, relatively high. Arterial O2 sat is 85%, yet on the right side, there is no left to right shunt. Her PA sats, SVC, IVC are all, kind of equal. So there is no left to right shunt, but she has a significant hypoxemia with severe precapillary pulmonary hypertension. So my first question is here, why is she hypoxemic? So this is somebody with severe precapillary pulmonary, or the other question I will ask, why do people with pulmonary arterial hypertension get hypoxemic? What's the standard answer? You have somebody with primary pulmonary hypertension. Let's say.
Poor diffusion of oxygen, poor
Does-
oxygen exchange.
That doesn't cause that much hypoxemia. No, there is a much better explanation. Will patient with PAH get hypoxemic for one major reason? It is, nobody
Is it,
knows? Uh-huh.
is
Go.
it like maybe like extra pulmonary shunting?
Be specific. So shunting is a good idea, but shunting where?
Transpulmonary shunting.
Okay, that's one of the one I want you to know is when somebody has a pulmonary arterial hypertension, you get a secondary right to left shunt. Secondary. That's not a right to left shunt that was due to a left to right shunt, progressive PH, and reversal of shunt. So somebody who had no shunt at baseline, you develop severe pulmonary hypertension for some reason, then 30% of us have PFO. Then all of a sudden you open that PFO, it's a pop-up valve mechanism. Now you get a right to left shunt across that PFO. That's one of the most common reason for hypoxemia in PAH is that you open a right to left PFO shunt. Another shunt is, as some of you mentioned, as you mentioned, both of you, is yes, you can get shunt at the lung level. We all have a little bit of arteriovenous communication in the lungs. It's usually maybe 2-3% of the cardiac output. But when you have a pulmonary arterial hypertension, again, pop-up mechanism, you get more arteriovenous shunting. So it's a true shunt. That's why they get a true right to left shunt. That's why PAH gets hypoxemic for the most part. There are other mechanisms, but that's the big one, okay? The key here is not to think that that right to left shunt is the cause of the PAH. Overwhelmingly in an adult patient, PAH plus right to left shunt, unless you have a real ASD, VSD, PDA, in an adult, it's overwhelmingly actually just a pop-up mechanism, as long as you see just a PFO on echo and you don't see any ASD. There are other ways of proving it. So this is what we did on this patient. So we gave her adenosine. Okay, the PA pressure declined slightly. The mean PA went to 55. Cardiac output rose, as is the case in patients with cardiac output reserve. Always with the vasodilator, you will raise your cardiac output unless you have no cardiac output reserve, which is horrible. Horrible prognosis, means your RV is shut down. Okay, your wedge pressure didn't change. PVR went down. It was around 7. It went down to 4.7. Now, the interesting thing, arterial O2 saturation increased, and we were able to take her off oxygen. Okay, so with adenosine, she was off oxygen. Why? What happened?
So decreased PA pressure, decreased right to left shunting.
Exactly. It's the same thing as the congenital case on a much milder degree. You decrease the PVR, you reduce the right to left shunting. You decrease the right to left shunting, which is driven, as much as it is driven by pressure, it's more driven by the difference in resistance between PVR and SVR. That's what drives your right to left shunt. So you reduce the PVR to SVR, especially you reduce the PVR, you reduce the right to left shunt, and then her arterial O2 saturation went up. Okay, that's one, that's one way of telling, well, this is not Eisenmenger here. Okay, she's not having severe PAH and right to left shunt from a prior old chronic left to right shunt and Eisenmenger syndrome. It was so easy to reverse that PVR and shunt. That's an indirect cath hint. Of course, by echo, you can prove it that there is no true shunt. There is no large ASD or large VSD. Here's another hint I want to tell you, very, very important point. It's in the guidelines too. If you have somebody with severe PAH, your VSD and ASD has to be sufficiently large to attribute that PAH to the ASD and VSD. So even if you find not just a PFO, PFO is definitely benign. It's nothing. It's salutary to have a PFO. Even if you find an ASD of 1 centimeter or a VSD less than 1 centimeter, those are usually benign. So per ESC guidelines, they express it clearly. PAH with small ASD, they use less than 2 centimeter, or small VSD less than 1 centimeter. Those are innocent incidental bystanders. Those are not the cause typically of the PAH. Those are just shunts that were there and that are actually now helping once you're having that PAH. It's been shown many decades ago that patients with a primary idiopathic pulmonary hypertension who have a right to left shunt do a lot better than and live a lot longer than PAH who don't have a right to left shunt. That's why one of the treatments used to be atrial septostomy. You create a right to left shunt. It's a pop-up mechanism. It helps the lung eliminate some of their flow and dump it on the left. Okay, it helps the right heart not fail, and it helps increase the systemic circulation. So definitely don't close those shunts. Those are secondary shunt, innocent shunt. So just know that. I wanted to highlight this point. That's one of the common right to left shunt we will see, what we call the secondary right to left shunt, through a PFO or through a tiny ASD or a tiny incidental VSD. You got it? Going to stop here. I had one more case that you can read it. Maybe I'll send you the slides. But any questions at this point? And I would say that this patient is not responsive to vasodilator by our definition. The PA pressure should drop to less than 40 to call it responsive. It should drop more than 10 to less than 40. Yet she is responsive by other means. Her PA pressure is of a different flare. Her PA pressure hasn't changed much, but her PVR has dropped. Her cardiac output has gone up. The two components of PA pressure, cardiac output multiplied by PVR, have changed. So it's a nicer PA pressure. Even though she did not fulfill the definition of responsiveness, she has responded in some ways to pulmonary vasodilators. Okay, any questions? No questions, anybody? All right, well, thank you all for attending. All right. How do I leave here?